Hi, my name's Jyoti Patel. I'm a thoracic medical oncologist at the Lurie Cancer Center at Northwestern University. And I'm happy to talk about the impact of electronic health records on the physician-patient relationship. These are my disclosures. I'd like to talk a little bit about background for open notes, some of the innovation that we're doing with electronic health records, how this has impacted our relationships, go over a couple of case studies, and then perhaps develop some guidelines for how we can overcome these hurdles. So essentially, this is rooted in signature legislation from 2016, the 21st Century Cures Act. This was widespread or sort of wide-reaching legislation that had broad bipartisan support that really looked at developing pathways for drugs and devices to address the opioid crisis, to improve mental health services, but a large part of it focused on greater interoperability between health systems and the adoption of electronic health records. The Open Notes rule, which has been in effect since April 2021, is legislation that provides immediate access to health information in a medical record, and it includes everything from consultation notes to laboratory and pathology notes. There's certainly some exceptions for mental health or privacy and security concerns. Open notes certainly have presented a large opportunity for many of us. We know now that medical records are no longer written solely for clinicians. There's good evidence to suggest that having access to medical records enhances communication, compliance, and improves outcomes. It gives us an opportunity to extend the visit. There is data also that by removing sort of stigmatizing language that we may heighten feelings of empathy and build trust between patients and physicians. And so certainly there are many things that we can do to enhance understanding. In the oncology setting, this has been assessed. This was a study looking at patients in a radiation oncology practice in California to see whether or not they felt open notes was beneficial. Most patients felt, again, that they had improved understanding of risks and diagnosis, that they gleaned important information that they missed in person. But a small number of patients, importantly, felt that they were more worried after receiving their notes. 4% of patients even regretted reading their notes. So how can we do better? Do oncologists feel the same way? This is a study that was done prior to the advent of open notes. And they looked at oncology providers and then other non-oncology physicians. And up to 70% of both physicians and non-oncologists felt that they may be less candid in their documentation about cancer diagnosis and prognosis. What can we learn from other countries that have had open notes for some time? So in Sweden, for example, they've had 6 years of open notes. In this survey of oncologists felt they were certainly spending more time writing notes. They felt that there was perhaps that this was helpful. Patients were more prepared for their visits. But a large number of doctors also felt they were more restrictive in what was shared in a note, that the patients were more worried than before. And in some, the oncologists just concluded that they were moderately, or the authors just concluded that oncologists were moderately positive, despite this opportunity, again, to share information and to partake in shared decision-making. I'd like to talk about a case study of a patient that I saw. So this is a 47-year-old woman, a triathlete, never smoker, really healthy, who developed some chest pain. She ultimately underwent a CT scan that showed a mediastinal mass. The biopsy was consistent with thymic cancer. It was localized, so she was treated with curative intent with chemotherapy and radiation. So tough treatment, certainly. She had a nice resection, but had ongoing toxicity with neuropathy, chest pain, and arthralgias, and wasn't back to her prior functioning, but was still doing well, but had really felt that she had ongoing toxicities that were not getting better. We started her surveillance imaging, and about a year after she completed therapy, she underwent the CT scan, which showed that she had a paratracheal lymph node in her previously irradiated area. It was small, so I was a little bit on the fence about whether we should do anything. Because it was only 8 millimeters, I also thought watching would make sense. she saw there was something abnormal and wanted to pursue treatment or pursue investigation. So she underwent a PET scan. There was low-grade uptake in that lesion. She ultimately had a biopsy on a Tuesday. The pathology was signed out on Friday. I was out of the office on Friday afternoon. The result was released over the weekend, and I was not going to see her until Wednesday. During this time, she accessed the report and went into a significant depression. She knew the cancer was back. And when she came to see me on Wednesday, she was like, I can't do any more, and I'm going to do hospice. I've had too many toxicities. Our discussion about treatment options, about ways to approach this, essentially she just shut down. And it took a lot of backtracking to get her into the state where I could give her a path forward and talk to her about different treatment options. She's now on treatment and doing really well a year later, but we talk about that period as one of, she's still angry about the results coming through and not having a clear path the moment that she saw the results. Other clinical scenarios that we see, unfortunately not infrequently, include a patient who is found to have new brain metastasis on routine imaging, and seeing her oncologist 3 days later, even though these are imminently treatable and she'll be able to stay on systemic therapy. A gentleman who I recently saw with EGFR lung cancer and recent minor progression, after we had an appointment to go over all of the treatment options, his wife sends a detailed my chart really about prognosis, estate planning, and his mental health over the weekend. Really tough conversations to have through a patient portal and to glean from the medical record. A patient who's on surveillance who has had curative therapy, now sees scans that describe a tortuous aorta, abrupt cutoff of the upper lobe, crazy paving in the left lower lobe, a hypodensity in the liver. His wife is absolutely convinced that he has recurrent disease that I've been hiding. One thing that I am active in and I think is important is to really develop patients that can be advocates and are well educated about their cancer. So ASCO, our professional organization, has cancer.net, and it has been launched for almost 2 decades for people with cancer and their caregivers. It's the editorial board is oncologists and is really healthcare workers that have vetted this information and tried to give the best information to patients. Most of our patients most of our visitors identify as patients or family members, and it's got broad and global reach. The idea is to give patients, again, and their caretakers as much information as they can get and put things in perspective with a doctor's voice. There are lots of disease-specific guidelines. There's information about how to reach a patient portal, how to get information about abnormal tests. This patient that I was talking about led me to actually blog about how to use your patient portal effectively. And certainly we can get deeper understanding, but we also need to be prepared with how we're dealing with it. And some tips that I have are certainly that with results, you need context. You need to understand the language, understand when you're getting those results, the timeliness of those results. So how are we relaying information? When are you talking to your healthcare provider? And then finally, how can you use a portal to answer straightforward questions? Questions about sort of prognosis are very difficult to do by email, certainly by online communication. I think the biggest piece from this is that we want to have transparency. We want to use electronic health records effectively, but there's been a significant change in how we deliver information. Prior to electronic instantaneous delivery, I would take time to print a report, annotate it, comment it, and then go to the clinic visit to really show that we had shared understanding of next steps. Now, when patients get results before I see them or before we have established trust, I feel like we're pulled in opposite directions, that the patient really doesn't, the results are in medical jargon, there's no context, and I'm spending the visit justifying the language and explaining the clinical significance. So clearly we can do better. There are new opportunities for communication, and particularly in cancer care where misunderstandings between risks and benefits of treatment are common. Having this repository of information that we can talk about is helpful, but we need to do better. Perhaps incorporating infographics and hover boxes could enhance this understanding without overburdening care providers. Certainly, all oncologists benefit from training in more supportive, inclusive language. The patients need solid advice on how to use their portals most efficiently and most effectively. Thank you.